Hello, I'm Dr. Albert Rizzo, the Chief Medical Officer of the American Lung Association, and welcome to the Respiratory Report. This segment from the American Lung Association and HCPLive.com features researchers in the pulmonary field who have received funding from the American Lung Association's Awards and Grants Program. Today's guest is Dr. Jaime Hook, Assistant Professor, Division of Pulmonary Critical Care and Sleep Medicine in the Departments of Medicine and Microbiology of the Global Health and Emerging Pathogens Institute at the Icahn School of Medicine at Mount Sinai. Thank you for being with us today.
Thank you for having me. I'm looking forward to sharing with you the progress that we've made in the lab because we think there's a good chance it could be translated into new treatments for patients with lung disease. We're very excited about our findings and we're grateful for the American Lung Association support that made the work possible.
Oh, you're welcome. Thank you. So I understand your research is exploring new therapies to deal with influenza. Please go on and tell us why this is so important.
So, flu infection is a major cause of global mortality and a frequent cause of pandemics. Pandemic flu viruses have caused more than 50 million deaths in the past century alone, and the risk of a new flu pandemic could be as high as 3% per year. Moreover, seasonal flu infections cause nearly 500,000 deaths every winter, and rates of hospitalizations and deaths in the current flu season are higher than they have been in more than a decade. Now that avian flu is also a rising threat, it's very clear that flu has been and remains a serious threat to public health and the global economy. Death from flu infection often results from a secondary pneumonia that happens when flu-infected people inhale Staph aureus bacteria from its usual location in the nose and into the lungs. Anyone who has the flu can develop a severe flu staph co-infection, but the people who are at the greatest risk are babies and children. The cornerstone of treatment for flu staph co-infection is antibiotics and antiviral drugs. But these drugs don't work as well as we want them to because once flu and staph damage the lung, antibiotic and antiviral drugs can't fix it. And in addition, antibiotic and antiviral drugs are increasingly threatened by worsening rates of drug resistance among flu and staph strains. So new approaches to treatment for flu staph co-infection are critically and urgently needed.
So then please tell us what your approach is to assessing these new therapies for flu staph co-infection.
Our goal for the ALA-funded research is to develop new treatment approaches that protect flu-infected people from a fatal staph co-infection. Our research shows that flu promotes staph co-infection by disrupting the lung's normal defense mechanisms in lung alveoli, which are the lung's air sacs. In healthy alveoli, the epithelial cells that line the alveoli continuously secrete liquid onto the alveolar surface that keeps the epithelium healthy. That secretion is caused by function of an ion channel called CFTR, because if we block CFTR function, then the secretion stops. Importantly, the secretion has a role in helping alveoli prevent infection. We inhale staph and other bacteria from the nose all the time, especially during sleep, but we don't usually get pneumonia. One of the reasons we don't get pneumonia is that in healthy lungs, liquid secretion helps alveoli clear particles and staph out of the air sacs and into the airways, where we can cough them out. I'll mention here that all this part is already known. We didn't discover it. But what we did discover is that flu blocks CFTR function to stop alveolar liquid secretion. And at the same time, flu activates another ion channel, the epithelial sodium channel, to cause liquid absorption. So in this way, flu completely changes our usually secretory alveoli into absorptive alveoli. And in this new absorptive microenvironment, staph that are inhaled from the nose can stabilize an alveoli, start a co-infection, and cause lung damage that's fatal in mice. But we're excited to find that if we treat flu-infected mice with a CFTR potentiator drug called ivacaftor, we could rescue the liquid secretion, block staph co-infection, and prevent death.
So what is the American Lung Association funding going to help you do next?
We're excited about the future of this ALA-funded work for two reasons. First, it gives us the first understanding of how alveoli respond to the flu, and we can build on that, which I'll tell you more about in a moment. Second, it opens the door for clinical trials to test whether ivacaftor could protect against staph co-infection in people who have the flu. And we think a clinical trial might be feasible in the not-so-distant future because ivacaftor has a good track record. It's already been used for many years in people who have cystic fibrosis, and it's already known to be safe and have few side effects. So we also think that new treatments like ivacaftor, which target the lung and not the virus or the bacteria, will continue to be useful even as new viral and bacterial mutations that make the pathogens resistant to existing antibiotic and antiviral drugs. So I mentioned then that our ALA-funded research is ongoing. In our ongoing work, we're trying to refine our understanding of the liquid secretion in alveoli, which cells are responsible for it, and which cells should be targeted for new drugs that might work even better than ivacaftor. So specifically, we're working to identify which alveolar epithelial cell type secretes the liquid in healthy alveoli and which cell might be the most vulnerable to damage by the flu. The traditional thinking is that alveolar type 2 cells express the most CFTR and are therefore the likely liquid secretors. But alveolar type 1 cells sit next to alveolar type 2 cells in alveoli and also express CFTR. They might contribute as well. In fact, they might be the most important cell type because they make up 97% of the alveolar surface, but their contributions are not yet known because type 1 cells are hard to study in the lab.
So, how do you begin to determine the contributions between the AT1 and AT2 cells?
To identify which cell type drives the secretion, we used existing resources to make transgenic mice that are missing the CFTR protein specifically in type 1 and type 2 cells. The cells that are missing CFTR also express a fluorescent protein that helps us identify them under the microscope. We then use a special method to see what effect that CFTR deletion has on alveolar liquid secretion. So we perform a surgery in mice in which we place cannulas in the trachea, pulmonary artery, and left atrium of the heart. Then we remove the heart, lungs, and cannulas together and arrange them under a confocal microscope. We attach the tracheal cannula to a ventilator, which we use to inflate the lungs, and then we attach the PA and LA cannulas to a pump, which we use to perfuse the lung vessels. When we're finished, what we have in front of us is a live, intact, inflated, perfused lung that we can use to view single alveoli or groups of alveoli. Finally, we use tiny needles to microinject a fluorescent reagent into the lung's alveolar air spaces. As alveoli secrete liquid, the fluorescent reagent becomes diluted and loses fluorescence. So using this method, we can see alveolar liquid secretion in intact alveoli in real time, and we can measure the effect that CFTR deletion specifically in type 2 and type 1 cells has on the secretion rates.
And what do your preliminary data show us?
So our new preliminary data show that CFTR function in type 1 cells, the cell type that isn't traditionally thought to be the liquid secretors, is in fact critical to alveolar liquid secretion. And in addition, we found that type 1 cell CFTR function drives the clearance of particles and staph from alveoli. So these new findings show that type 1 cells are major contributors to alveolar health and defense. And for our next steps, we plan to evaluate the extent to which type 1 cells are targets of flu infection and flu-induced alveolar damage. If they're especially vulnerable to flu, then new precise treatments that restore CFTR function specifically in type 1 cells might be both beneficial and free of side effects from other cells. Finally, I'll wrap up by saying that the findings we've generated with ALA support are the first to define physiological responses of alveoli to flu infection. Key data show that flu blocks CFTR function to inhibit alveolar liquid secretion and promote staph coinfection in alveoli. But the CFTR potentiator drug ivacaftor is protective. Our new preliminary data show that type 1 cell CFTR function is critical to alveolar health and defense, and they suggest type 1 cells might be major targets of flu-induced alveolar damage. So these findings support CFTR potentiator therapy as the new treatment strategy for flu staph coinfection, and they also inform the design of new CFTR potentiating therapies that might have more precise alveolar sites of action, better drug efficacy, fewer side effects, and perhaps resilience in the face of new pandemic viruses and new viral and bacterial mutations that threaten the efficacy of existing drugs.
Well, thank you very much, Dr. Hook. Very important work. And we thank you for your time today, and we wish you good luck in your pulmonary research and the furthering of your career.
Thank you so much.